everyone, I'm Ariba Tariq Lutfi and welcome to Sante's weekly broadcast, Nazaria, the power of experience. We have been having conversations with Pakistan's leading ophthalmologists up till now, and we continue to have these conversations. So let's share it with our viewers and especially the new ophthalmologists of Pakistan. So today I would like to introduce one of the top ophthalmologists in Pakistan and the highly prestigious professor and very well-known professor all around, Professor Dr. Sanaullah Jan. He is a professor at Vitreoretinal Ophthalmology, Hayatabad Medical College. He is the director of Pakistan Institute of Community Ophthalmology. He is also a former president of OSPKP and president-elect of Pakistan Vitreoretinal Society. So, Assalamualaikum, Professor Sanaullah. Do you have any few words that you want to say about Nazaria and experiences?
Thank you very much, Shariba. First of all, I would like to say thanks to Sante team and its management. What you people are doing is really admirable, and it's actually practically needed on ground. Creating awareness and getting tips regarding different aspects of a common but a complex disease like glaucoma will not only be helpful to our postgraduate trainees, but also for our young colleagues. I really appreciate and admire Sante team to take this initiative.
Thank you so much, Professor Sanaullah, for saying such nice words and it is actually a pleasure of mine that you are here with us today, and actually I'm very honored that I am in your presence today. So let's get on with the questions and our conversation. So I would like to ask you my first question, that what is glaucoma in your words, basically?
Okay, glaucoma unfortunately is very complex disease, and at many times it may be very confusing also. But at the same time, this makes it very interesting specialty for ophthalmologists and for eye care individual to explore. Coming to glaucoma definition, I would define it as a group of eye pathologies, not as a single entity, in which intraocular pressure is at a level which causes continuous or interrupted but progressive damage to intraocular structure, especially the optic nerve. This damage may be obvious in the form of optic atrophy or optic dystrophy when we go for fundoscopy, or it may show as atrophy of iris or glaucoma flaken lens opacity, which we do get after angle closure attacks. Now, nerve fiber layer changes, which occur much earlier than visual function compromise, they can be detected much earlier on gadgets like OCT. Visual field and visual function compromise, that comes later on, but you do get typical visual field defects in this disease.
Okay. So
now there are primary glaucomas and there are secondary glaucomas. Yes. We all know that. I would not go into detail of that classification, but we then further classify them as open angle and close angle. And sometimes we do get features of both closed and open angles with very variable presentation.
Yes. So these are basically, you have very technically explained what is glaucoma and overall what do you think about glaucoma as well. What are the aspects that are not really focused or not taken into consideration in our common practice during the diagnosis of glaucoma?
Yes, so probably diagnosis of glaucoma. Now I assume you are talking about open angle glaucoma, because usually it has no symptom in earlier stages until late when central vision is affected or compromised. Because angle closure glaucoma, it's difficult to miss and it presents with acute symptoms. I would say glaucoma is more complex than what our young ophthalmologists or eye care individuals usually think of it. Although visual field is one of the common tools which we use routinely in diagnosis and prognosis of glaucoma, but there are two other measures of visual functions which are actually not commonly used and not in focus. These are contrast sensitivity and color vision, the typical yellow-blue defects you get in glaucoma. These actually visual function measures are not routinely used to diagnose glaucoma. They are affected earlier than visual field. And if we focus on these measures also, we may detect glaucoma or diagnose glaucoma much earlier. Second, my point would be that we diagnose glaucoma very casually. Raised intraocular pressure does not mean glaucoma, and same we can say that normal intraocular pressure does not exclude glaucoma. So what my advice is not to hurry and worry in diagnosis glaucoma. All protocols need to be followed, including detailed history, examination, investigation, with proper diagnosis. Our diagnosis, once we diagnose it, we have to treat this patient and follow this patient for rest of his or her life. So we need to take all protocols to note all the protocols that they have to, we have to follow them appropriately. Third point would be to stay vigilant about secondary glaucomas, especially if you get raised intraocular pressure in one eye. For example, if you don't dilate, we can very easily miss pseudoexfoliation. If we don't go for gonioscopy, we can miss angle recession glaucoma. If we don't examine thoroughly the interior chamber and vitreous for the typical Haki cell of ghost cell glaucoma, we can diagnose it as pulmonary or primary open angle glaucoma. Similarly, signs of lens subluxation, pigment dispersion can be missed easily if pupils are not dilated. So we need to be very vigilant about secondary glaucoma, especially in unilateral cases.
This was very actually eye-opening for, I'm sure, many as well as myself, that you have to be very careful and very gradually actually diagnose glaucoma or a patient when they come to you. So Professor, you mentioned about history, that history is very important, and a person should, and an ophthalmologist should not hurry or worry while diagnosing or treating a patient. So what is the importance of history in glaucoma management?
Dr. Ariba, detailed history is the most important part of glaucoma management. In fact, in medicine, the management starts from detailed history of the patient. If we say family history of glaucoma, we may delay the diagnosis of glaucoma in our patient, and we may miss the opportunity to screen or diagnose the family members. Then if the patient say if they are on beta blocker and you don't ask that what are you using, systemic medication. So the pressure lowering effect of systemic beta blocker, then you can wrongly diagnose primary open angle glaucoma as normal tension glaucoma. The pressure may be in normal level due to the systemic intraocular pressure lowering effect of systemic beta blocker. So like if you don't take history of trauma, you will miss traumatic glaucomas. If you don't ask about the steroid use, you will miss steroid-induced glaucoma, and you may wrongly label it as developmental glaucoma or primary open angle glaucoma. Especially in cases of normal tension glaucoma, if we don't take history of acute systemic blood losses, say after accidental trauma or due to previous major abdominal surgeries, or we don't ask about breastfeeding failure to the babies in childbearing age females, we may wrongly diagnose cases of normal tension diagnosis. Actually, they may not be normal tension glaucoma cases. The feature which you get in glaucoma are not very specific. The optic disc cupping, which is one of the diagnostic feature for the glaucoma is not pathognomonic or specific glaucoma. You do get glaucoma cupping in many other pathologies causing optic atrophy. So this is very important. And also you have to take the note of socioeconomic status of the patient. So if you are going to select a particular treatment option, that is very important. So history clues, in my view, is one of the most important aspect in regard to diagnosing, selecting the treatment option, and also regarding the prognosis of the disease.
Yes, actually very understandable that history is the most important part in treating glaucoma, because the patient could be misdiagnosed if the history is not properly taken by the ophthalmologist. Professor Sanaullah, how do you treat your patients once they are diagnosed with glaucoma?
Okay, now this is not very simple question to answer in few sentences.
Yes, yes,
Uh,
yes.
I would like to mention that I got tendency to go for surgical treatment more frequently and much earlier because of many reasons in my practice. Most of our patients are poor; they cannot afford lifelong medical treatment with glaucoma. Our patient got poor compliance with, regarding anti-glaucoma eye drops use. They got poor compliance for follow-up. Although follow-ups will also be needed after surgery, but if successful surgery is executed, I expect better intraocular pressure control, and we don't lose much if he or she misses few follow-ups in between. I would like to conclude that for selecting most suitable option for the particular patient, one has to balance the benefits and risk of intraocular surgery. But we have to keep in mind that medical therapy is also having a lot of side effects, which may sometimes be very serious and unbearable and may compromise the glaucoma therapy compliance. In this regard, cost matters for most of our patients in our community. So most of the time, this cues us tilts towards the surgery in our patient much earlier and more frequently. I would like to summarize it to you what I do in my practice. If the intraocular pressure is very high, say about 35, I
Okay.
would definitely go for surgery first until the patient refuses this option. If the intraocular pressure is between 30 and 35 millimeter of mercury, and the patient is of poor socioeconomic background, again, I would advise surgery as my first option. But if I expect good compliance plus affordability, I may go also for medical option first in these patients
Okay.
in this range of intraocular pressure. But if the intraocular pressure is below 30, I would choose medical treatment almost most of the time. This will be my first option. If poor compliance or patient cannot afford this treatment, or if I find that there is visual function deterioration during follow-up of this patient, then I may change to surgical intervention.
Yes.
I usually don't use selective laser trabeculostomy or ALT in my patient, and I feel these are actually procedure for very selected patients, especially in our community.
Okay. So majorly the socioeconomic background and the compliance is how you go about your treating your patient in glaucoma.
Exactly. We have to individualize our patient. The protocol which we get from the West may not be practically as beneficial as they are in the Western world to our community.
Yes, agreed. Because there are a lot of health barriers and a lot of financial barriers in our society as compared to other countries. So, Professor Sanaullah, we also talked about normal tension glaucoma. You have been mentioning it a lot of times, and I think it is a very important subject. So, how do you handle or treat normal tension glaucoma?
Well, now normal tension glaucoma is the most difficult area of glaucoma to manage actually. Starting from diagnosis, you need to keep in your mind some of pathologies which can present as normal tension glaucoma. As we already mentioned, cupping is not specific for glaucoma, and you can get in many of other optic nerve pathology which can cause optic atrophy. Like say after acute blood loss, major blood loss, after road traffic accident, after abdominal surgery where you get major or extensive blood loss, after pituitary apoplexy. So detailed history, especially uh, asking for previous record just to document progression, because progression is one of the key factor for diagnosis. This may be very helpful in regard to its management. Family history also important. If the other family members are having normal tension glaucoma history, so there's high chance that this factor also helps in diagnosis of normal tension glaucoma. We need to do phasing investigation and visual field, where you do get typical visual field related to normal tension glaucoma. We need to ask about systemic medication, like we already discussed beta blockers, so that we don't wrongly diagnose cases of primary open angle glaucoma as normal tension glaucoma.
Yes.
So most of the time, these normal tension glaucoma patients are also having history of migraine, peripheral vasoconstrictor phenomena like Raynaud's phenomena, and sleep apnea syndrome. Many of them are also having, say, if they are systemic, having systemic hypertension, and they are using antihypertensive medication. And if they are taking them at night, that gives them blood pressure decrease, which can also compromise the optic disc perfusion at night. So the hypotension related to antihypertensive medication is also important, and we have to take note of that. Now, once diagnosis is there, now here comes the treatment stage. If you can treat the risk factor, like if you can do something about sleep apnea, you treat also the migraine and also the other pathologies which we can associate with normal tension glaucoma, you do that. You also take note of this, you can just change the timing of antihypertensive medication, and you can ask the cardiologist colleague if they can take these medicine with proper with blood pressure for blood pressure control, but not at night, at some other time, say. So these are also important aspects to cover. Now, coming to intraocular pressure in normal tension glaucoma, if it is in high teens, this situation in my practice, I would call it a better situation. You can reduce this intraocular pressure to low teen, and in my experience, I feel that these patients do very well in long term in regard to preservation of visual function, visual field, everything. But if the pressure, intraocular pressure, is already in low teens, it's very difficult. And I hate to say that, but in my experience, such patient they do very bad in regard to visual functions. Ultimately, they may go blind.
Okay. So it is that severe. Normal tension glaucoma is that much of a risk for patients to go blind. Professor, I wanted to ask you another thing. You are mentioning about treatment of glaucoma. So what are your thoughts about fixed combination dorzolamide and timolol, such as codorzal?
Sante is one of the, pharmaceutical company which is very much focused on the quality control of all of its products. The codorzal is as effective as many of other imported drugs which we get. They are much more costly even. And one factor which I would always keep note of that is that this is national company, and most of the money which we are actually we spent on this buying all these expensive imported drugs. This money is going to foreign countries, not to our. So this is one of the major factors which actually every one of us has to consider while prescribing medication. If the quality control is, if the efficacy and safety profile is same, so codorzal is, I would say, is as effective as many of other imported drugs.
Thank you so much for mentioning about economy of Pakistan as well its effectiveness and quality. Professor, since we are about to end the session, so I would like to ask you, what is the take-home message for the trainees and the young ophthalmologists in Pakistan and around the world who are watching you and respect you?
Thank you, Ariba. I would conclude in, I would say, three actually advices for my young trainees and young ophthalmologists. First of all, we need to follow all standard protocol while managing glaucoma, especially while taking history, examination, and investigation. Once we reach the treatment stage and follow-up stage, we have to modify our protocols according to our own circumstances and our own patient and community needs. We don't have to follow the Western evidence which is there. You can modify them. Unfortunately, we are only having the surveys and the studies and the evidence which comes from Western countries and developed countries. So my concern would be to produce local evidence, come up with the local studies and local evidence which is innate to our community and our patient also. That would be more beneficial. The strategies which are based on these surveys and studies will be more beneficial to our community. So this would be my first advice. Another would be because glaucoma is a field very complex and there's still a lot of things to explore in glaucoma specialty. There are a lot of gray areas. There's so much to determine that even coming up with one definition of glaucoma is difficult even for the experts in this field. So my advice, if my younger colleagues can take this subject or this specialty as for their future career, that would be another, because if we come to subspecialty services and that the services are more focused, ultimately the patients are going to benefit and the society is going to benefit more. So thank you very much, Ariba.
Thank you, Professor Sanaullah. Thank you for joining with me on Nazaria. आपने हमें टाइम दिया और हमारी व्यूअर्स को जो है वो अपनी इतनी अच्छी नॉलेज जो है वो बताई और हम लोगों को काफी अच्छी डिटेल में भी आपने एक्सप्लेन की चीजें, एंड इट वाज ऑल समथिंग न्यू, दैट देयर वर अ लॉट ऑफ थिंग्स that were new from your talk that I learned today. So thank you so much for joining me in this project, and it was really lovely having this talk with you. So do you have last few words to say, and then we can end this session?
Thank you very much, Ariba. I'm thankful to you and Sante team, and I hope my young trainees and my young colleagues from ophthalmic fraternity, they will be coming up with more evidence, more studies, and which on those we can then base our national guidelines how to manage glaucoma. So I'm hopeful this is going to happen in near future. Thank you, Ariba.
Thank you so much, Professor. It was really lovely having this session with you. Allah Hafiz.
Thank you.